Hello, PDIG, Podiatric Dermatology Interest Group members and members of the general public. I'm Joseph Frankel, and I'm joined today with Steph Finlayson. Hi, Steph.
Good morning. How you doing?
Good. How are you? Or good afternoon or good evening, wherever you are in the world. Today, we are going through the monthly dermatology wrap-up from Podiatric Dermatology Interest Group. We are a Facebook group comprising a few thousand, I think we're up to 3,000 podiatrists internationally, and we have a very special interest in podiatric dermatology. For those that are joining us for the first time, the format is as follows. We will be reviewing one case that's been shared, our case of the month, one dermatosis, where we'll discuss some of the ins and outs of it and some of the treatments and some of the pathophysiology, and we'll also focus on one product. So what have we got on today's show, Steph?
Today's a good one. We're looking at keratoderma for our case today, which is a really interesting one that popped up in the group recently. Lots to discuss there and unpack, something that I think a lot of podiatrists see regularly and maybe don't know that they're seeing. So interesting one to have a chat about. We're going to also look at Erythema Ab Igne, say that a few times, condition, just to broaden some horizons. And then finally, we're going to have a little look at Flaminal as a product that we can use, which I'm quite excited by, because even though I'm in wound care, it's not something that I have used a lot of yet. So I'm looking forward to your wisdom, Joseph.
Excellent. All right. Thanks, Steph. Let's just jump straight into it. I'm going to share my screen for those of us that are joining us on YouTube or on Facebook or on other visual media. So this was an interesting case, courtesy of Kim, who shared it's quite an interesting one. She's a female, age 65, who had some mild to moderate hyperkeratosis of the soles, as you can see, Steph. And she's been to
moderate dosage.
no. It's was mild to moderate. Now, sort of moving on to moderate to severe. She's tried a number of different topicals and even got to the point where she saw a dermatologist and actually had a biopsy on it, of which the biopsy showed histopathologically that it was indicative of eczema. And what was interesting was the histopathology excluded psoriasis, of which it has quite a psoriatic appearance. And I'll show you the next slide, the next image rather, which has somewhat of a psoriatic appearance of the nails. But if we go back to the first slide, what are your thoughts off the bat, Steph?
Definitely the psoriasis pathway. I mean, just looking at that middle slide and seeing that really clear line of demarcation with that redness. So I think I'd probably be thinking something along the lines of psoriasis with potentially a secondary fungal element to it as well. And I think, when you're seeing callus like that, immediately you think there's more going on here than just, poor foot hygiene, or definitely a condition behind this. But where do you start? How do you figure out what the condition is and how you're going to treat it?
Well, that's a great question. I mean, histologically, that can give you tons of information, which the dermatologist treating this did that. The thing with histology is, and I wonder if this is a bit of an MRI syndrome, whether it's a case of it picks up everything and it doesn't necessarily give you all the relevant clinical links. So if you refer a patient for an MRI, it'll tell you that there's bursitis irrespective of whether or not the patient is symptomatic. Yeah. To me, this is likely initially psoriatic or chronic eczematous, where it's then become what's called acquired keratoderma. And so, even though that doesn't necessarily show up histologically, I mean, to me, having seen a number of cases of this, it does look keratoderma-esque. And keratoderma is quite an interesting condition. It's essentially a chronic thickening of the stratum corneum. So it's almost like it's the next step in the process of hyperkeratinization. So HK, hyperkeratosis, is an excess production of keratin, almost exclusively in the stratum corneum. But what happens is if that gets so chronic because there's some sort of underlying driver, whether it's trauma, whether it's an inflammatory condition like psoriasis, the outer epidermis becomes so thickened that it's just it sort of re-traumatizes itself. So even though strictly speaking the epidermis doesn't scar, it's almost like it's a form of scarring in the sense that the tissue has fundamentally, structurally changed itself. So it's quite an interesting one. And some of the comments and responses to the treatment were focused on biologics, which are wonderful treatments, which I'll outline briefly as to what biologics are and how they work. However, in a case like this, if it's acquired and it's now become entrenched in a sense, it's quite difficult for a biologic or any other treatment to be effective to the point that it would completely resolve this. And so therefore the goal shifts towards management and symptomatic relief rather than to remission and resolution.
Well, I guess bringing it back to if you have a patient just with regular callus from increased pressures and poor foot hygiene, that you still need to treat at the same time as looking at the causes, right? So
Correct.
you get those patients that will say to you, oh, can I just go away and change my shoes and it'll be fine? And you go, well, no, because it's already there and you need to do something about the fact that it's there. So it's that double approach. And I think, if you're seeing a person like this in the clinic, you should be thinking, what can I immediately do to relieve some of this while we figure out what's going on?
Yes.
So for her, from a layman's perspective, even if I wasn't aware that this was keratoderma and a chronic case of it, I'd be looking at, how can we increase the moisture that's getting into this foot? How can we offload? And whether that be sharp debridement or whether you're looking at mechanical offloading. And then figuring out. So I think sometimes when you see these cases, it's very overwhelming. And when you're not a dermatological special interest nerd, such as yourself, Joseph, it can be very overwhelming. But just bringing it back to those basic elements of, I've got a foot in front of me that looks like this. What can I do short term to buy myself time to figure out what we're going to do to get a long-term resolution for this patient?
Correct. And often when I find chronic cases, it's about staged treatments. So you're quite right. There's the short, the medium, and the long-term treatments. So definitely short-term treatments, you're right. Moisturizing, footwear, even hosiery and socks, activities, sharp debridement, buffing debridement, if that's even a thing, where we use them for those that aren't podiatrically inclined. We use a kind of sanding disc.
Wet wraps.
Yeah.
Or something like this.
Wet wraps are another option. We can outline wet wraps in another episode, but essentially it's a form. It's a form of real deep moisturization. So yeah, there's a number of things you can do. I will say very briefly for those in Australia, and I'm not sure what the regulations are outside of Australia, but the process of getting on a biologic is a little bit lengthy. And so they're a wonderful option where essentially they're a targeted injection therapy, which fundamentally changes the underlying pathophysiological disease process. They are very expensive, but they're also very effective, but they're only prescribable by dermatologists for a pharmaceutical benefit scheme price. So they're available through a GP, but they're four-figure per injection, so quite expensive. So if you do have a patient that you think is suitable for a biologic and they're at that stage in that staged process, then by all means explore that. But it's worthwhile understanding that it can take months to even years to actually get on a biologic. Yeah.
And I think that's a really important thing when you're talking to your patients, that you're not just going, oh, biologics are fantastic, and they think they can just pop to the chemist and grab some. It's a process, and it's part of their overall health journey, not just about what's happening in their feet.
Correct. That's correct. Great. Okay. Hopefully we've covered enough with that. I'm sure we could talk about this for ages. What have we got next, Steph?
So next we're going to have a look at our condition, Joseph. So what is your favorite condition of the month?
Well, this was actually not on PDIG, but it was mentioned to me by a friend of mine, Jason Lim, who's over in WA. Hi, Jason. So he asked me whether I'd ever heard of something called Erythema Ab Igne. I think that's how I pronounce the last word.
I bless you.
Which I hadn't. And essentially, it is chilblains in reverse.
Ooh.
Yes, quite interesting. So it's a vasospastic disorder whereby vasodilation is the primary physiological response, and it's stuck in it. The words erythema means reddening, ab means from, and igne means fire. So it's red from fire. So my guess is it's been around for a while because it's Latin, and anything Latin is old. So,
An ancient condition.
absolutely, it is an
I
ancient
feel
condition.
like overachievers who chillblains is just a walk in the park and they want to really ramp things up the other way.
Well, that's it. I mean, for those who don't know, I'm in Melbourne and Steph's in Queensland. So therefore, dare I say, Queenslanders are probably more Erythema Ab Igne, and
Surprises
Melbourne.
me that I haven't heard of it because, I
Likewise.
think it's just that we spend our entire lives in a condition of erythema ab igne, like we're just constantly hot.
So it's quite an interesting one. It has a very, and I should be sharing an image, but I imagine a lot of people listening to this on their drive to or from work or doing the dishes. It has a reticular, which is a net-like pattern. So it's almost like a reactive hyperemia, but a hallmark feature of it is hyperpigmentation. So what happens is over time, because of the chronic vasodilation, we get some leaky capillaries and we almost get a hemosiderosis type presentation. So a little bit of tanning almost.
So
and the hype,
like a residual bruising?
kind of.
And does it just target the digits similar to chilblains, where you get that sort of, is it individual digits or is it more widespread because it's a dilator?
Well, it can technically affect anywhere where there are capillaries, so therefore the whole body, but typically you'll see it mostly in the chest or in the legs. Interestingly, we do see it in people who use their laptops too often. So the heat actually, it happens on their thighs.
Oh,
Yeah. Quite interesting.
With anything these days.
Yeah. So yet another vote for using a mobile phone more often.
Then it would be in your hand though, right?
That's true. Yes, you'll get erythema Ab Igne on your hand. But it's quite interesting. So chilblains can have an erythematous component, but only because after the periods of vasoconstriction, when the vasodilation occurs, so in other words, you get cold, the blood vessels constrict, and when they reopen again, because of the underlying structural damage, that floods the area with erythema. That floods the area with too many blood cells and other chemicals. Whereas with erythema ab igne, it's just constantly being flooded. So the damage happens without going through the process of vasodilation, vasoconstriction. So the vasospasm happens in the sense that the blood vessels are just open for too long, basically.
And so, I mean, you wouldn't think that it would be particularly painful, maybe uncomfortable, itchy.
Yes, correct. All the typical vasospastic symptoms.
But not that like pain that people will experience with chilblains.
Well, what's interesting is chilblains pain is often when it moves from one phase to the other. So initially the pain is a vasoconstrictive pain followed by a vasodilatory pain, whereas this is just a vasodilatory pain or an itch. So there is some overlap with this and Raynaud's, also with reactive hyperemia, and also with cholinergic urticaria, which we can deal with at another time.
Showing off.
Cholinergic urticaria, is basically exercise-induced hives. So it's quite interesting. But if we can link this back to our keratoderma patient, tissue inflammation and damage can happen on literally many different levels. So what's interesting is when it comes to vasospasms and vasculitises and keratodermas and hyperkeratoses, it's all about which layer of the skin it's attacking, because we know that the skin is multi-layered, multi-dimensional organ. And so it's really quite interesting if you want to nerd out on the pathophysiology of, where are things going wrong, quite literally, at what level. So it's quite interesting when you have a look at it a little bit deeper. Yes,
what would be your treatment pathway for this particular patient?
Well, it's identifying the underlying cause of the erythema. So, get off your laptop, don't sit too close to the heater, etc.
Don't live in Queensland.
Say again, sorry?
Don't live in Queensland.
Or that.
Sending a few back, actually, so you can have some in Melbourne again.
Okay.
Will we miss the coffee?
Well, it's pretty hot today, so we'll take some of it. What's interesting is cold actually isn't a form of treatment. It's rather about removal of the cause. So it's not about getting a person colder; it's about removing the heat, and then allowing the skin to help itself, which is so much of dermatology. You need to put the skin in the right position to do what it does, basically. Yeah.
Excellent. Well, shall we have a chat in, flames, talking about Flaminal now? 10 minutes left there. So Flaminal wound care product?
Yes. It's quite a multi-use dressing. I'm going to give you the finger, quite literally, because I'll spare everyone the
Scandalizing people in our very first podcast. Ease them in.
Yes, although I will show maybe another time what I actually did to myself. I did share it with Steph when I closed my finger on a drawer and developed a lovely hematoma underneath. So I'm currently using Flaminal. And Flaminal is quite an interesting. It's quite an interesting dressing. It's somewhere between an alginate and a hydrogel with enzymatic antimicrobial chemicals in it. It's quite fancy. It's quite a fancy and it's quite an interesting one. So Flaminal basically is a clear gel. It's quite thick, and you apply it to a wound, and it helps to bride, but it also helps clot. Because of the alginates in it, alginates are really good at helping to form clots and helping with that first stage of the wound healing continuum, which is hemostasis. So Flaminal is really quite versatile, and you can use it on those wounds that are not too sloughy, but a little bit sloughy, that are a little bit on the dry side, that could do with some moisture. And because of the enzymes that are in it, it actually is naturally antibiofilm and also naturally antimicrobial. It's not as punchy, I would say, as iodine or silver-based products, but I personally love to use it post-operatively on nail surgeries.
Oh, really?
Yep. So
what did you use before you moved to Flaminal?
I actually can't remember. It's been so long. No,
Like a Bactigras or something?
Yeah, I dabbled with a few other antimicrobials, but I found that often in most cases, if we've got a background amount of antibiotic therapy, because often ingrown toenails are a little bit mucky and infected to begin with, then the necessity to have another really strong topical antimicrobial was unnecessary. But I also found that because typically surgery involves some form of bleeding, and because in most cases of podiatric nail surgery, there's no incision, but there is a little bit of bleeding, because of that secondary intention type of wound healing, we need some sort of an alginate. So I find it's really effective. And it can also say in contact with the wound for up to 3 days, which is in line with most of my post-op dressing regimes, which we can talk about in another show. But it's quite a good one. Do you use hydrogels very often in your wound care practice, Steph?
I have used hydrogel mainly when I have exposed bone in a wound and I want to keep things nice and moist, and making sure that there's some antimicrobial properties right deep in there, not just sort of overlying. So I haven't used it a great deal, but they're helpful in certain situations. I think I like the idea of using Flaminal, not that I do too many nail surgeries these days, but post-operatively, because once you're through that, that first dressing change, and then they're coming to you a week later, you do often have like a very dry, scabby wound. You tell people to go and do their saltwater soaks at night and gently soft debride, with a cotton tip or whatever you can to try and move that scab from the nail matrix. But I think they get a bit scared, or they don't like poking at it or whatever, and it's always better to have a patient that doesn't like to poke at their wounds. But still, I think I can see the benefit there of having something and going, grab this, and you apply it each time you change the dressing. You don't have to come back to me and do it weekly or whatever. So yeah, I think I might start adding it to my wound care arsenal.
Excellent. I'm converting people one podcast at a time.
You need to disclose something. Are you?
No, not at all. Not at all. In fact, actually, I should say that we are not sponsored by any of the products that we outline, or any of the medical conditions that we discuss either.
We'll see how well this goes.
Yeah. Well, I think that's about all we have time for today. Thank you for joining me today, Steph.
Thank you. And I guess we should say, if anybody comes across any really interesting cases, head on over to PDIG. And there's a fantastic online community there of podiatrists and some interlopers who are non-podiatrists who we welcome anyway, because it's always good to get new perspectives. And and post on there, you'll always find welcoming help and feedback when you need it. Yeah, it's been lovely. Thank you, Josie.
Pleasure. Have a great week ahead, everybody. Keep derming, and we will see you soon.
Bye.